Go ahead and show us how to use a robot.
Okay. Can you guys see the? Yes. Okay. Good. So typically, in terms of before I scrub in, I go over the planning, but I'll sort of do this in a little different order since we're in the lab here. But usually, first I go before the patient's even prep and drape. I go ahead and mark out some normal landmarks, including midline, where the crest is, top of the crest is, and also whatever level that I think we're going to be at. I sort of mark it up just based on palpation, so I have a rough idea of what I think, where I think the insertion point should be. Can you guys see the planning station?
Yes.
So while they're getting set up, typically I walk in and I'll have them go through all the pictures to make sure that I'm happy with the registration. So in this case, I usually start off with the axial view, and one of the things to notice about this particular software is that usually we're used to seeing things reversed, but here right is right, left is left. So usually based on the scrolling through the pictures, we measure out the pedicle and all three planes to figure out what size screw we need. And so typically for an adult, it'll be 5.5 or 6.5, or depending on your manufacturer, it'll be a 5 or 6. Those are the most common diameters that we use. And in terms of length, typically, we've been sort of, as you guys know, neurosurgeons are not quite as aggressive with the length of the screw. But as I'm getting more confident with this, actually, I'm in some cases where, especially in the older osteoporotic bones, I am sort of trying to get bicortical purchase, which I feel much more comfortable doing so with this technique because, like I said, it's fairly accurate in terms of where you think you're going to be and where you need to be. So we'll do this first, and then we'll check it on a different plane. So we'll check it on the sagittal plane. Make sure that I'm happy that I'm not nicking the top or the bottom of the foramen. And I'll do this for each level. And so this is a segmental registration that I'm talking about.
So the right upper image is essentially sagittal cuts.
Exactly. And I'll do that for both pedicles. And so once I'm happy with one level, I'll ask them to go to the next level. So here we've opted to do L5S1. And so we'll go down to the next level. So that was 5. We'll go down to S1. So typically, at this level, I'm not as concerned about a little bit of facet violation, but at the superior level, we are more cognizant of that because we try not to violate the integrity of the adjacent facet. But in this case, we're trying to fuse that level, so here we're not as concerned about that. And then same thing, we'll check this through the two planes, the axial and the sagittal.
So Jay, have you noticed that since utilizing more robotic technology that you're actually changing the size of the screws that you typically used before you started using robotics?
Yes, in the sense that there's a lot less guesswork. I know, and I'm sort of optimizing what the size of the screw, if you will, for the patient. And in terms of both the diameter and the length, absolutely. So once we're happy with that, I usually have my tech here sort of show me a projected skin view because I sort of want to see where my incision needs to be. Now, although because most of my patients do need a central decompression, I typically do a midline incision if I can. So that's where that part is more appropriate because I'm trying to figure out how big I need to make my incision and sort of have a rough idea where. But in this case, for the sake of simplicity, we decided to do sort of a paramedian mini Wolti approach for this. So in this case, what I'll do is once I'm happy with the planning, I'll go ahead and have the robot arm be sent to the entry points for both L5 and S1 so I have an idea where I need to make my incision. So let's go ahead and send the robot arm to L5.
So Jay, can you sort of comment on that again? You said it can help you make the skin incision?
Yeah, I'll show you that in a minute, but are we registered already? Okay. Okay, so can we send? Oh, the registration, right. Sorry, I guess I glossed over that part. So the registration for this, and I probably should have done a better job explaining this during my talk, but once the patient's on the table, what we do is we attach the robot arm to the patient, either through a post in the iliac crest, or if I have an exposed spinous process, we can use that. And then we move the robot arm into position to take a oblique and a AP X-ray with these markers in place. So there's a cover that goes on your C-arm, and it has these markers that you can see there on your screen. So the software can figure out the registration. Yeah, so what we do is, you want to bring this down so I can show them? Oh, really? All right, so this part will attach to the robotic arm where it needs to be to give us an AP and lateral view. And then that's when you take your 2 shots of fluoro, and that information is mated to your preoperative CT scan to get a registration. So theoretically, if everything goes right, all you need to do is take 2 shots of fluoro for this entire case.
So can you step? I'm assuming you can step away from the patient while even the fluoro scans are being.
Absolutely. In fact, usually I'm not even in the room. My NP does that because it's non-invasive. I mean, in terms of the procedure, they're just attaching the marker for the fluoro. So this is a registration part that we're going through that you're seeing on your screen. So that once the machine accepts the 2 fluoro views, it sort of goes through, and this is the machine sort of checking all the bony anatomy to make sure that the pictures are acceptable, or the quality of the fluoro shots are adequate to get a matching registration at each level that you're interested in putting screws in. Okay, so now the machines has accepted that, and now we can send to our entry point. So the reason I do this is I sort of want to see where the entry point for the purposes of making my skin incision. So this is for 1? Okay, so this is S1, so I'll make a little mark right where my tool there bottoms out on skin, and then I'll have them send it to the next level, L5. Now at L5, S1, they're usually right on top of each other because so this is about 2 or 3 millimeters apart. Okay. What's that? Okay. So in a real patient, I'll have them move out of the way. In this case, I probably don't need to do that, but I'll just make a stab incision. I will tell you that there's a couple different ways you can think about doing this, depending on which system you choose to use. But for the systems that I use, I typically make it so that it's big enough for my finger to sort of do a little finger dissection. And not that I need to do a lot of finger dissection per se, but it needs to be at least that big in order for me to get my cannulated screws in.
So if you're doing a decompression, where would you incorporate that into your workflow?
If I'm doing well, meaning sort of like that one case I showed you where she had 3 incisions. In a case like that, I would have made my midline incision exposure first, so that I have a spinous process that I can put a clamp to, and then the robot arm, this part would attach to the spinous process in order for me to get the registration. Once I do that, then I will go ahead and put my screws in, or rather all the K-wires in, check some X-rays to make sure I'm happy with the position of the K-wires, and then put all the screws in. Once the screws are in, this part comes off, and I do my decompression. Does that make sense?
Yes.
Okay. But for the purpose of this, we're just pretending that we don't need a central decompression, so we're just putting screws in. Now, once I make my skin incision, I usually have a retractor of some type. We have a little angled, almost anything will work. But in most patients, the skin is pretty flexible, and so I have this this longer blade that's designed to go through this guide attached to the robot, and this is designed to cut fascia. So, okay, so I'll use this to pass that, so it cuts fascia right up until the bone. And then I'll put this dilator back down. And this part has a sharp dissecting tip right here, and then this tube that goes over it to dissect away the soft tissues. So then I'm sort of feeling as we're going down. And so I've bottomed out at the tip on the bone, and then I'm sliding my outside portion to dissect the soft tissue away. Now, once this is all the way down on bone, this outside part, I'll do a partial clockwise turn so it comes off a few millimeters off the bone, and then take out this, while holding it in place so that this outer sleeve doesn't move, I'll take out the inner cannula. And the reason I back that out a little bit is because, as you guys can see, this is what's called drill guide, and this is the part that's designed to sort of park itself on the bone. And it's got sharp teeth so that it sort of bites into it, so it prevents movement while you're doing the drilling and the Kwire placement.
Would you guys mind turning on the one of the spotlights?
Were they not able to see that?
Thanks. Yeah.
Okay. So once this is in, now this is where a lot of the tactile feedback comes into play, because you have to tap this into position without it skiving. And so part of this is sort of holding onto the base. My pinky usually is on the patient, and usually, I'm sort of cognizant of the fact that depending on the patient's anatomy, I know that certain entry points are maybe more prone to skiving than others. So I'll know that it's got an inferior skive potential, lateral, medial, and so forth. So I have that in my mind as I'm tapping to sort of feel for that if that's happening. And so this is the part where you do need to pay attention, because this is the part where you just blindly trust robot and just whack this in. This is where you can get the skiving. And then it's important to sort of start off with some light taps, and as you sort of feel it bite, you can give it a few more firm taps until you're sure that it's got a pretty good purchase. And then we have a drill here that's preset to the determined depth, so it doesn't go all the way through. Now, what I usually do is once I go down this cannula and I can feel it bottoming out at the bone, I lift it off a couple millimeters because I want the drill to be on at full speed before I start going to the bone, because I don't want it to start drilling or rotating while on the bone, because that can also cause some skiving. So I'll back off a few millimeters, start all the way, so it's on full power, and then I'll slowly make a perpendicular or tangential motion until I've bottomed out. And then I'll reverse it back out. So the tactile portion of this is very important. And sometimes people are afraid to start the drill at full speed because they're afraid that, there's just a fear that it might be too strong. But in fact, it's better that it's at full speed so that it just moves through the bone easily instead of having to force it.
Does that drill have like a depth, like limiter, so that you don't?
Yeah, the maximum distance is 30 millimeters, because that's usually enough to get you through the base of the pedicle and partially into the vertebral body.
Got it.
So now, once the initial pilot hole is made, this device here is called a reduction tube. And so this is a part that the Kwire goes through. And the purpose of this is, the reason we don't put the Kwire in directly after this portion is that there's some bone debris that's been built up from the drill. And so this is designed to sort of partially tap that down. And then usually we also like to have this down and then give a little bit deeper, because it just is a little bit more security in the vertebral body. In patients where the bones are a little bit soft, you can even just feel it manually with your hands. If the bone quality is actually a little harder, I give it a few taps with a light hammer so I know that it's in there.
So again, at this step, how do you know that you're not too deep, that you haven't penetrated like the anterior cortex?
Because you can feel the bone, right? It's not body, it's not going through. I mean, if you've actually penetrated through the anterior cortex, it'll be, you can feel it. You can feel the soft tissues anteriorly. With this, but also with the K-wire, you know. Now that I put the K-wire down, I can feel bone. I'm in solid bone, at least at the inferior edge. I mean, you know, if this is partially, let's say it's too lateral or too medial, so that I can't really feel the lateral aspects of the bone, just where it's bottoming out. And so if I'm off a little bit medially, laterally, inferiorly to where I think I am, potentially when I put the screw in, because the screw's got a bigger diameter, I could break out of the pedicle. But at the very least, I know I'm not too deep because I'm feeling bone. And that's actually something I should have mentioned when I got the question about the putting the screw in without the K-wires. You know, I think I probably should have made a comment or made the point that more I think about it, I think I would, if it was me, I would still put the K-wires in for the reason that I just talked about. Because if you skip this step, if you skip putting the K-wire in and you're just putting the screw in directly, it is a little bit of a leap of faith, you know, because you better be where you think you are, otherwise you've blown out that pedicle. Whereas if you've had a little bit of a skive, and you know, once the K-wire's in, you take a picture, find that you're maybe skived a little bit, you can always redirect that K-wire. But if you put that screw in, you know, for the most part, in most patients, you know, getting a second hole for a good pedicle screw purchase can be difficult. So because of that, although the chance of that happening is pretty low, I think, in my mind, I think it's worth a little bit of extra time to put the K-wire in, because I don't think it really slows you down that much. Okay, so once this is in, only the K-wire stays. So I'll tap out the instruments. And I'm applying some pressure downwards on the K-wire as I'm sort of turning the reduction tube and pulling it out.
So you're generally not even getting like lateral X-rays at this point?
No, only once everything's in. So then I'll get this K-wire out of the way, and my tech will already have sent it to the next screw. And so this is what I'm talking about. You know, there is really no, the problem with standard navigation is that, you know, there's still some error possible just from the surgeon's hand. Here, it's a fixed point, so all you're doing is moving up and down in a preset trajectory. So it really eliminates that error of the human hand. So I do this just again to make sure there's enough of a fascia cut. Okay. And I'm bottoming out there with a sharp portion, and then again dissecting out the soft tissues with the outer dilator until that's down on bone. And then I give it a partial turn to make sure that's a few millimeters off the bone. Taking out the inner cannula. The drill guide with a sharp teeth is going on the bone. And then I'm giving it a few taps to make sure I have adequate purchase. And this part is not just a sensory tactile, but you can also hear it. You know, you can hear sort of the teeth having a good bite.
Jay, I'm assuming that if you had placed the first screw, that it could potentially get in the way when you're trying to put in a guide wire now then.
Exactly. That's why I just get all the K-wires in and put the screws in later. Exactly. Okay, again, I'm lifting off the bone a little bit, a few millimeters, starting the drill, and then advancing. And again, just like we talked about before, we do have to look at our preoperative studies before we do this, because in certain cases, you may be going through more of a facet because of the patient's anatomy. In those cases, the bone tends to be harder. And so as you go drilling through, you'll meet a lot more resistance. But if you know that that's what you're going to be expecting, you won't be as surprised, and you can more confidently apply more tangential pressure. So I'll give that a couple taps to make sure it reduces. Okay, I'm feeling bone there, solid. Reduction tube's coming out. And now I'm ready to take my X-rays. Well, you know, we can do the other side, but I think you guys probably have gotten the gist of it, so why don't we take some X-rays?
Is there a functionality of the robot where you can actually put the screw through the robotic arms?
You know, I think that's coming. Absolutely. Yeah.
Because this part of it kind of seems redundant then, right? I mean, you've put the guide wires in, but it seems like if you just left the robotic arm there where it's already created the exact channel that you need, that your screw should go right through that.
It should, and it does most of the time, but just once in a while you're surprised, you know? And so since we're all averse to, you know, since our first mantra should be do no harm, you know, I do like to check. We have a... Thank you. I don't know if I should be putting lead on. I mean, we don't do this. We don't do this in real life. Why am I putting lead on? So, Jeff, this is the first time I've put lead on in like 4 years.
Sorry about that, man. But when you do take these fluoro spot checks, you're just like stepping away then?
Yeah. Yeah. We're just stepping away behind the lead screen or moving 6 feet away. Yep. You got to come south a little bit. Yeah. And probably a little bit of a...
Yeah, we're not actually seeing the X-ray image.
You want to do just a little bit of this? Okay. There you go. What's that? Okay. Okay, there you go. Let's try that. Okay, that's good. So here it looks like we've entered the pedicle in the appropriate place. It's probably, especially the L5 one, could be a bit deeper, but it certainly hasn't violated the medial wall of the pedicle there. So then let's get a lateral. Straight lateral.
Okay.
Why don't you, can you save that AP?
KJ, you have about 8 minutes.
Okay. There you go. So.
Looks good.
Right. The S1 pedicle maybe looks a tad low, and this is when I'm not quite sure. I asked my rep to bring up the sagittal planning portion to see whether it jives with where it needs to be. I mean, to me, that looks a little low. That's probably okay. She's got a big pedicle there. Okay. All right. So once all the why don't you come on out? So once we're happy with our K-wire position, why don't we go and put some screws in? I think we have time, just so they can see how that flows. So I'll put the 5 screw in first. So I'll ask for a tap. And depending on the system you're using, you know, some of the systems have towers or sheaths, or, you know, in a patient like this, it's really not as essential because the patient is thin, so there's not a whole lot of soft tissue. And this is where you need to become familiar with your system, because again, especially when the bone is, if your patient is a bit more elderly and the bone quality is not the best, you don't want to over tap. I don't like to over tap. I just want to tap enough to get things started. And so depending on the system you're using, and depending on the, you know, the pattern of the, I'm blanking, help me here, Aaron, on the screw, the thread, yeah, the thread pattern, you know, every screw will advance a certain amount depending on how many turns you give it. And so generally anywhere from about 10 to 15 turns should be enough to get you started. And then I'll back it out. I always under tap also. Because if you just start tapping and just you have your mind on something else, it goes in too deep.
Would you be able to use a navigated screw at this point?
You mean, oh, absolutely, absolutely. So usually I would have an assistant with a retractor in, holding that out of the way, but I am caught on a little bit of soft tissue. One of you guys hold that? Aaron, put some, okay. Got a bovie? No, okay. So occasionally, if this does happen, I would use a little bovie just to coagulate the soft tissue. That sort of, you know, that sort of binds itself up on the thing. But in this case, okay. So again, in my mind, I was counting how many turns I was giving it, because you know, you have a rough idea of when it should bottom out. Plus, it's feel. You'll sort of feel it sort of tightening, and of course, you don't want to over tighten it on the bone, but you want it to be fairly flush. And the reason you want to pay attention to that is because you know, you don't want to have to go back later and, you know, adjust the screws. I mean, you can do it, but it's just an added step. So you just want it to be at the level or depth that you want the first time. So, you know, typically I would put all the screws in like this. How much time do you have, Jeff?
About 5 minutes.
Okay, then we'll just do one screw. And this comes off, pops off. It just stays. Okay. All right, let's check an X-ray.
Can you guys put the camera on the X-ray monitor again? Thank you.
Okay, lateral.
I think you need to point it to the one on the left.
There you go. And then table up. I got it.
No, the other one.
Why don't you come out a little bit? It's hitting the arm. There you go. How's that? Pretty good?
No, we're not able to see the screen on the X-ray monitor. I think the camera may be maxed out going left.
Okay. Okay.
There we go.
Okay. All right, let's get a picture.
Looks good.
Okay. So you can imagine that typically I'll get the screws in on both sides at all levels. And then once I'm happy with that, I'll just go and pass a rod. And depending on the system you're using, you can use small stab incisions and pass your rod. Or in a case like this at L5S1 usually, I can just do everything through that small incision. So I'll just drop the rod down under direct vision and put the set screws in.
Nice work, man. Thanks a lot,
Okay.
Jay.